Hi, everybody. I just want to say welcome to all of our participants that are rolling in. Just going to give it a minute for everyone to make it into the session, or anyone that's just starting their lunch break now. We'll kick it off in a minute when I see those numbers slow down. Okay, great. I think we have our first group with us. So I'm going to kick it off because we have an awesome session and I'm really excited to get into it. So welcome everybody to today's webinar on reclaiming 2SLGBTQIA+ health, advocacy, and access to queer health in Alberta. And I am super excited to welcome Dr. Keith King, who's going to be presenting on the topic today. But first, I'm going to read a land acknowledgement and go over a couple housekeeping items. Keith, would you mind giving me the land acknowledgement? Thank you. So while our attendees might be from anywhere in Canada or even necessarily across the world, we are hosted today by MacEwan University School of Continuing Education, which is in Edmonton, Alberta on Treaty 6 territory. So I'm going to read a land acknowledgement for our treaty area. We acknowledge that the land on which we gather in Treaty 6 territory is the traditional gathering place for many Indigenous people. We honor and respect the history, languages, ceremonies, and culture of the First Nations, Métis, and Inuit who call this territory home. The First Peoples' connection to the land teaches us about our inherent responsibility to protect and respect Mother Earth. With this acknowledgement, we honor the ancestors and children who have been buried here, missing and murdered Indigenous women and men, and the process of ongoing collective healing for all human beings. We are reminded that we are all treaty people and of the responsibility we have to one another. Thank you, Keith. Just a couple housekeeping items for everybody. Just so you know, this webinar is being recorded. So if you find it's a really good conversation that you want to share with someone afterwards, or if you have to pop out a little early, everyone that registered for the session will be getting a recording probably early next week. We do have the chat and the Q&A features active. While we will probably take most comments at the end, feel free to pop any comments or questions into the chat or Q&A at any time, and we'll discuss everything at the end. I also want to clarify that this is a safe space. If anybody is being rude or aggressive in the comments, I will be removing you from the Zoom session. And with that, I'm going to hand it over to Keith.
Great. Well, thank you, everyone, for joining today. For starters, I wanted to start off just by talking a little bit about positionality and why it's important today and in healthcare. Positionality is sort of where we're socially located in our lives and how ideas like power and social position influence our identities and our access to society or services in society. These can include things like racialization, health, illness, gender, sexuality, ethnicity, relationships, disability, abilities, different abilities, history, education, age, all of those unique things that we all have about ourselves that put us in location to other people and to systems of power in our communities. I want to introduce myself as well. My name is Keith King. I'm a PhD student, so thank you for giving me the doctor moniker early, Mackenzie, but I'm not a doctor yet. I will be soon, hopefully. But this is, I lost my train of thought, I'm so sorry. So yes, I'm a PhD student in nursing at the University of Alberta. I'm also a Métis person, a child of my mother, who is mixed Russian and Métis, and my dad, who's an English settler. I'm from up in Treaty 8 territory, north of Peace River, where I was born and raised. And then I moved to Edmonton, or Masquatchie, Waskahigan, here in Treaty 6, where I did some of my schooling before moving around quite a bit, different places in the world to learn different things. I did my master's in Australia, some research in the UK, and then came home to the Métis homeland here in Edmonton to do my PhD. But I do want to also highlight that this is a limited and abbreviated presentation in terms of not being able to cover all the things that we could talk about when thinking about reclamation of 2SLGBTQIA people's health. We could spend a whole university course talking about several of the topics here. So I've done my best to include some of the relevant histories and information, but I just want to acknowledge that it's not even close to capturing the many, many, many diverse stories and truths about the very diverse communities that I'm going to talk about here in what is now called Canada. And also I want to share that my experiences also influence this presentation. And so I want you to be really critical and think about how the information that you get today blends with your own knowledge, values, beliefs, and those things, and take it in through your own frame. So things that we're going to talk about today, we're going to talk about a bunch of stuff, but a little bit of 2SLGBTQIA plus history, both from a healthcare and legal perspective, because I think those are important relationships, as well as the contemporary challenges that we face. I am an Ayakweo, or a two-spirit person, and so that also influences this presentation. We're then going to talk a little bit about the work that continues to inform the forms of resistance and reclamation of health by 2SLGBTQIA plus people in our communities. And then we'll wrap up by imagining the simple things that we can do to help change things for the better. Hopefully that is what you signed up for. I want to talk a little bit about pre-colonial Indigenous sexuality in Alberta, because today Alberta is home to many different First Nations people, and I've listed some of them there on the slide. And it's also part of the Métis homeland. Prior to colonization, many First Nations saw gender and sexuality as fluid, permissible, and very much a part of nature and human nature. There were various permutations of sexual and romantic relationships that existed, and often gender variants, what we would now call trans identities, and sexually diverse people were held in high regard. And there's lots of stories about different, in different Indigenous languages, about the ways in which gender and sexual variance was accepted and often even honored. Contemporarily, the term two-spirit is used as a pan-Indigenous term to describe gender and sexually diverse people who are Indigenous to North America or Turtle Island. The term two-spirit came to some two-spirit elders through ceremony and were shared at a gathering in the early 90s. And the term two-spirit came from the idea that a person's body could contain or embody or express gender of both men and women. I think more contemporary thinking sort of expresses, and again, it's individual to different nations, but more contemporary thinking is along the lines that a two-spirit person, or in my Michif language, Ayakweo, is somebody who exists beyond the binaries that were introduced by colonialism. Unfortunately, when European colonizers came to Turtle Island, many changes came with them. Colonists often described gender variant Indigenous people as sodomites, or the language that was brought from Europe didn't have words, or the words that they used were based in religion, and often saw gender variant and sexually diverse people as problematic, sinful, and to be eliminated. There's an image here that was taken by a colonial, or that was painted by a colonial painter, and it showed what they called a berdache, which is like a French word that was used to describe gender variant people. And this was called the dance of the Berdache. And this was, I believe this was Cherokee warriors dancing for a two-spirit who was a healer or a spiritual leader in preparation for battle. And the European interpretation of that was that the two-spirit was somehow going to imbue the warriors with special skills for the ensuing battle. But again, a lot of this history has been eliminated through residential schools and colonization. So we're in a process of reclaiming that knowledge and bringing it back to our nations and to our people and to the broader contemporary world. I want to talk a bit about the medical history of queerness. So there were lots of theories of pathologizing, and queerness has been pathologized at many points in history. Dr. Edmund Bergler was an early doctor who viewed queerness as a disease, and really through this thinking about gender variance and sexual diversity, saw that there was some internal defect or external pathogenic agent, like maybe a virus or we'll talk about Freud, but like an overbearing mother or some other external force that might cause homosexuality, and that those events could even occur before a person was born or after. And so there was this idea that medicine might be able to intervene and prevent queerness from happening. Of course, then came Dr. Freud, who brought his theories of immaturity. So Freud saw the development of humans as a path of becoming more and more mature as you approached adulthood and going through phases of like oral, anal, and phallic maturity. And the final phase of adult heterosexuality was sort of becoming fully a man. So again, you see the patriarchy influencing this thinking there. But Dr. Freud regarded expressions of homosexuality or behavior at a young age as a normal step of development, but you would grow out of it and become a heterosexual as you became a fully mature adult. So ideally, he saw that as a phase that one would outgrow, but a person could get stopped or arrested in their development, and that's where a person would be, in their stunted development. And this sort of psychological theory of queerness carries on today. In my own life experience, there were a number of people early on in my journey that said, "Oh, it's just a phase; you'll grow out of it," and that sentiment comes from this way of thinking about gender and sexuality. Karl Heinrich Ulrich was a scholar, and I believe he was not a physician. He was a legal scholar, but saw homosexuality as something that occurred naturally, and typically argued that people who were born queer were born different, but that it was a natural different that was affecting a minority of people, like left-handedness. And Karl Heinrich Ulrich's work was in some ways liberatory at the time. Now, when we think about gender biases, there's a few things that come to mind. And those early theorists or those early scientists or doctors who were theorizing in Europe about queerness, they were based in gender binaries. So it is ancient and Eurocentric, the male-female binary that dominates Western medical practice today. Most gender beliefs are based on this binary, and that binary is very well known. But there are also, over the last few years, we've been seeing emerging scholarship that shows that even though science loves a binary, there are still other binaries that can be explored and other ways of looking at these things. For example, the transgender, cisgender binary. You either are one or the other. And, I think some Indigenous thinkers and some queer thinkers would say that actually we don't have to use binaries to describe these things because each person is unique and our stories are all different. But because science does love a good binary, we still deal with these ideas of like trans versus cis, and they're always sort of in opposition to one another. Many scientific studies of homosexuality have contained implicit and often explicit binary gender beliefs as well. For example, there was an intersex hypothesis of homosexuality that maintained that the brains of homosexual individuals exhibited characteristics that would be considered more typical of the other sex. Again, it assumes that you're either a male or a female. And that essentialist belief that was implicit in this hypothesis is that an attraction to women, or people who are assigned female at birth, is a masculine trait. Whereas Freud saw lesbians as having a masculine psychology. So again, it's sort of, these theories sort of fed into each other and have led to this interesting history in medicine of categorizing people in these ways. Additionally, biological researchers have presumed that gay men have brains that more closely resemble women, or are recipients of extra fragments of their mother's DNA. Again, some of these theories have been disproven, but you can see that thread winding through history. Gender beliefs usually only allow for the existence of those two sexes. To maintain that gender binary, most cultures traditionally insisted that every individual be assigned to the category of man or woman at birth, and that individuals conform to that category for their whole life thereafter. These categories of man and woman are considered to be mutually exclusive, but there are some exceptions in history. In Plato's Symposium and in the Jewish Talmud, which describes 8 genders, and in my own teachings that I've received from Cree elders, there is evidence of additional genders. And I would encourage you to look up some of these ideas in your own time, because even just when we think about biological sex, male, female, we see naturally occurring intersex people. So again, lots to learn. These beliefs, though, have all led to and underlie the mid-20th century theories that children that were born with genitalia that were not closely aligned with either male or female had to immediately undergo assignment surgery to reduce their parents' anxiety or the physician's anxiety or whatever social pressure that the person experienced. And what we see now is that there's an emergent movement of intersex people who do not want to be medically reassigned because they were born naturally the way they are. And so they don't undergo a lot of these treatments, although it should always be up to the person what they want to do. Of course, there are religious, medical, and legal histories that are often entwined when it comes to healthcare. And I have a question for the group. Can anyone think of a medical problem that has religious or legal implications now? And there's many that have been in the media lately. Just going to open the chat box and see. Is the chat open, Mackenzie?
Yes, it is. I'm just waiting. Oh, someone asked if you could repeat the question.
Oh, yeah. Can anyone think of a medical problem that has contemporary religious and legal implications now? Some that lots to come to my mind, but I'd love to hear. Certainly circumcision, abortion, blood transfusions. Yeah, those are all great answers. Many mental health conditions, HIV infection or other reportable diseases. Yeah. Vaccinations, absolutely. Yeah, corrective surgery. We just talked a little bit about that for intersex people. Yeah, so there's lots of religious, medical, and legal implications when it comes to health. And what are some of the driving forces for those religious and legal interactions with medical practices? Who informs those decisions and relationships? You don't have to answer, but politicians, public personalities, white straight men, past beliefs being passed down, not necessarily explored. It really should be the patient or the person, absolutely. Social media, the loudest voices. Yeah, and I think historically, for much of Western history, official pronouncements on the meanings of different behaviors and different identities were primarily the province of religions, many of which deemed gender variance and sexual diversity to be morally bad. I mean, the Pope just announced that, it shouldn't be illegal to be queer, but it's still a sin. Yeah, absolutely, Patsy. The gender of psychiatry is very controversial, I would say, and problematic. However, as the 19th century came along, power started shifting from religious to a more secular authority, as same-sex behaviors and many other sins received increased scrutiny from the law, medicine, psychiatry, sexology, and human rights activism. It's largely through the activism of people from these groups that have led to changes. So eventually, religious categories like demonic possession, drunkenness, and sodomy are being transformed into scientific categories of insanity, alcoholism, and homosexuality, and then criminalized in a different way as well. And I'll talk a little bit more about that in a second. Oops. I want to talk just briefly about the impact of residential schools on Indigenous identities. Obviously, the legacy of Canada's residential schools and the forced assimilation of many Indigenous people into Christianity, as well as the sexist and misogynist laws that were enacted, including the Indian Act, had profound implications for Indigenous peoples' gender and sexuality. Yeah, absolutely, Ace. A lot of people aren't told about their intersex condition. There's a picture here of St. Mary's Mission School, which shows how the colonial gender binary of man-woman was forced onto Indigenous children through those genocidal and assimilatory process of Christianization. So forcing children to dress and behave in a way that didn't fit their cultures or traditions. Subsequent laws like the Indian Act, which I mentioned, forced gendered roles and patriarchal violence into Indigenous ways of being by disempowering women and erasing queer identities. And one of the most difficult stories I ever heard from a Two-Spirit elder was about having their hair cut in the residential school and being forced into, boys' clothing, despite knowing all their lives and being affirmed as a gender diverse person. And being allowed to wear what they wanted in their own communities, and how much that affected them later on in life. And I think that resonates probably with a lot of queer and trans folks who experience being forced to change as children to fit into their family or social communities defined roles for men and women. Moving a little bit forward to today, we see a contemporary medicalization of queerness. And again, it's not super recent history, but in 1952, the APA, the American Psychological Association, published the Diagnostic and Statistical Manual, the DSM-1, which classified homosexuality as a sociopathic personality disturbance. And then after years of additional study and input from sexologists, they updated it to a sexual deviation. So now it's moved out of the religious field and firmly into the medical literature. So people could then assumedly receive treatment. So psychiatrists, physicians, and psychologists were all working hard to try and cure these problems with living that people had in their minds. Sex researchers of the mid-20th century also studied a wide spectrum of individuals that included non-patient populations. So prior to sort of the mid-20th century, this was only examined really in the medical literature for people who were like hospitalized or receiving care or seeking treatment for this problem that they had. That skewed sample led to a lot of the medical literature around queerness being case report data, which obviously cast people in a slightly different light. Also, much of the research done before then was studies on prison populations. So the people who were already incarcerated for being socially deviant in the contemporary laws of that time. Sexologists, on the other hand, were doing field studies where they went out and recruited large numbers of non-incarcerated, non-patient populations, and were doing research in a slightly better way to more accurately characterize the way that people were living. From the 1950s and onward, sexology as a discipline really expanded. We saw important research in this area, and that included the work of Alfred Kinsey, who we all know, there were problems with his research as well, but they published a couple of really important reports, the Kinsey reports, that surveyed thousands of people who were not psychiatric patients. And they found that queerness was much more common in the general population than was believed. The now famous 10% statistic is nowadays sort of based on census data, now believed to be closer to 1 to 4%. But that finding was still sharply at odds by the claims of psychiatrists who said that homosexuality and queerness and trans identities were extremely rare in the general population. Another study by Ford and Beach, looking at diverse cultures and animal behaviors, confirmed the view that homosexuality was much more common than psychiatry maintained, and that it was found regularly in nature, which went completely against many of the teachings of various religious beliefs that it was an abomination, it was unnatural, etc. In the late 1950s, Evelyn Hooker, the sexologist pictured here, a psychologist, published a study in which she compared the psychological test results of 30 gay men with 30 heterosexual controls, none of whom had any psychiatric diagnoses. And her study found no more signs of psychological disturbance in the gay male group, which was a finding that refuted most of psychiatric literature at that time that said that anyone who was queer had severe psychological disturbances. So I really lift my hands to Evelyn Hooker for depathologizing queerness in this way by doing a randomized controlled trial. The events in 1973 did not immediately end psychiatry's pathologizing of some presentations of queerness. For in homosexuality's place in the DSM-2, they described a new diagnosis, sexual orientation disturbance. So SOD, also known as, regarded homosexuality as an illness of an individual with same-sex attractions if they found them distressing and wanted to change them. So this new diagnosis legitimized the practice of conversion therapy, which has now been outlawed in Canada, thankfully, and presumably also justified insurance reimbursement for those interventions as well. So you see how capitalism and the monetization of healthcare starts to impact here as well. So even though being queer wasn't necessarily considered an illness, if you wanted treatment or found it disturbing to be queer, then they could do these treatments. It also allowed for the unlikely possibility that a person who was unhappy about being heterosexual could also seek treatment to become gay, although I don't know if there's any documented cases of that. But I like that flipping of this because as things change, the opportunities to look at them in different ways come up. SOD was later replaced in the DSM-3 by a new category called ego-dystonic homosexuality. And this was, again, just indicated that the person was unhappy with being queer, but it became obvious to psychiatrists more than a decade later that the inclusion first of SOD and then EDH was the result of earlier political compromises that neither diagnosis actually met the definition of a disorder in the new way of thinking about psychiatric diagnosis. What about short people who are unhappy about their height? Why not ego-dystonic masturbation? So if you don't like masturbating, you can go see a psychiatrist for it. As a result, this idea of EDH was removed from the next version of the DSM, and that was in 1987. So by doing so, the APA implicitly accepted that a normal variant view of homosexuality in a way that wasn't possible 14 years earlier. Finally, in 1990, the World Health Organization removed homosexuality from the International Classification of Diseases. And as a consequence, debates about homosexuality gradually shifted away from medicine and psychiatry and back into the moral and political realms as religious, government, and military, media, and educational institutions were deprived of the medical or scientific justification for the exclusion of queer people. So this is a really important time for 2SLGBTQ people in regards to health, as they were less likely to be pathologized. Although, as I've shared, many of these ideas do carry on today because of the way our education system and things work. In terms of gender variance, of course, there's important historical milestones as well. Back in the 19th century, studies were beginning in Europe that ignored, of course, Indigenous and other knowledges of gender. They coined the term transsexualism in medical circles in the late 1800s. In 1949, the term psychopathia transsexualis was termed. And then you can see, as I went through the history of homosexuality in the DSM, you can see that there's several new diagnoses over time. In 1980, transsexualism was added to the DSM. 1990, ICD-10 had it still. 1994, it was shifted to gender identity disorder. So again, you can see that pathway where they start to depathologize the person for existing, but moving towards, how does that person's identity impact their mental health? And we arrive in 2013 with the DSM-5 at gender dysphoria, which is the current term that's used to describe transgender people who experience dysphoria about their gender. Again, this gradual shift, I think we will see another shift in the next probably 10 years, because gender dysphoria captures only gender identity related distress that some transgender people experience, for which they might seek treatment rather than their actual identity. In the DSM-5, it also articulates explicitly that gender nonconformity in itself is not a mental disorder, which is, I think, a wonderful change for our medical colleagues. However, we still have to educate them on this. And the picture here is a picture of, oh my goodness, why do I always blank on people's names? Oh my goodness. They were the first person to have gender affirming surgery in the United States, and they became quite a celebrity. And I can't believe I'm forgetting Christine Jorgensen. They were a military veteran who served in the war, and in 1952 returned to the United States after having gender affirming care in Europe, and became quite a celebrity. And that was sort of probably the first celebrity trans person to start to bring trans identities into the light in North American context politically. From the earliest days of colonization to 1969, we saw sodomy laws making sex between men illegal in Canada. In addition, a law enacted in 1892 made gross indecency between men illegal. So that included any affectionate touching, kissing, etc. And then that law was extended in 1953 to women. So that's when lesbians were made illegal, and other gender identities who were attracted to each other. In 1969, however, those sodomy and gross indecency laws were changed, making such acts legal under some circumstances. You had to be over 21 years of age, and you had to conduct your affairs in private. And some of our listeners may remember Pierre Elliott Trudeau talking about the government not having any business in the bedrooms of Canadians. However, those changes that happened in 1969 still made it illegal outside of a person's home, or if 3 or more individuals were involved or present. So Canada's criminal code continued to equate homosexuality with criminal behavior under many circumstances. It wasn't until 1987 that the criminal code repealed the offense of gross indecency completely. And at that time, the law continued to criminalize sodomy with some exemptions for husbands and wives and for 2 consenting parties above the age of 18. It wasn't until 2019 that the age of consent for sodomy became equal for all individuals at 16. So again, you start to see this overlap of medical and legal implications. Oh yeah, that's a great quote from Dr. Gabor Mate about the way that medicine and psychiatry are always looking for the problem inside of individuals rather than looking at the social conditions that we exist in. Wonderful. Oops. I want to talk briefly about HIV criminalization as well, because this is an important piece for 2SLGBTQIA people. In Canada, a person living with HIV can go to prison and be registered as a sex offender for life for not disclosing their HIV positive status to a sexual partner in some circumstances. While people are usually charged with aggravated sexual assault, due to the Supreme Court ruling that ruling that HIV non-disclosure can sometimes amount to fraud that invalidates consent. The Supreme Court has ruled that disclosure is only legally required if there's a realistic possibility of HIV transmission, but the interpretation and application of this legal test has been widely criticized as too broad. People can face charges whether or not they had any intent to cause harm or did indeed transmit the virus. And people have been prosecuted and convicted even if they had sex that posed negligible risk or no transmission. In Canada, there have been at least 206 individuals who've been prosecuted in 224 different criminal cases between 1989 and 2020. Most prosecutions for alleged HIV non-disclosure have been brought against men in this context of sexual encounters with women. The criminal law continues to be used disproportionately against people living with HIV from racialized populations. Black men are disproportionately represented among those prosecuted, and Black and Indigenous people are convicted at a much higher rate, acquitted at a lower rate, and more likely to face prison sentences compared to non-Indigenous or Black people who face similar charges. In most of those prosecutions, HIV wasn't even transmitted. There was only potential or perceived exposure risk. In recent years, there has been a reduction in prosecutions, and particularly against people with suppressed viral loads, reflecting the community advocacy by queer community members and a greater understanding of the scientific evidence. When a person is taking antiretroviral drugs and fully suppressed, the risk of transmission approaches zero. All of these trends, demographic patterns, and outcomes of HIV criminalization cases highlight the urgent need for criminal legal system to be better guided by science and by human rights principles in responding to HIV, and for government action to end the harms of HIV criminalization in Canada. And right now, there's a consultation going on with the federal government to look at changing these laws. Of course, all of these legal implications have led to public raids of bathhouses, brothels, and the surveillance, arrest, detention, and prosecution and conviction of queer, trans, and 2S people and spaces. These criminalization activities have led to the rise of pride events as protests, the sex worker labor movement, and sex positivity and education movements. Here in Edmonton, the Pisces bathhouse raid in 1981 was a perfect example of the hostility that many queer spaces experienced and continue to experience in Canadian society. There have been some wins. Bill C-16 added the words gender identity or expression to 3 places in our human rights laws. It was added to the Canadian Human Rights Act, which joined a list of identifiable groups that are protected from discrimination, including age, race, sex, religion, disability, and others. It was also added to the section of the criminal code that targets hate speech. So you can no longer speak hatefully towards gender identity or expression or sexuality. And it was also added to the criminal code dealing with sentencing for hate crimes. So if there's evidence that an offense is motivated by bias, prejudice, or hate, it can be taken into account during sentencing. Other important wins were the 1998 Variance versus Alberta rule that protected an Alberta-based teacher from discrimination in their job. In 2005, marriage equality was legalized here in Canada. We talked about Bill C-16. And then here in 2021, the conversion therapy ban was introduced, which is wonderful. So now that we've reviewed some of the historical, legal, and medical reasons 2SLGBTQIA people might struggle with healthcare, what are some of the contemporary challenges that might continue as a result of this ongoing legacy of exclusion and harm? And I'll open that up to the group. What are some contemporary challenges some people might face? And I see a few comments in here. Benefits for self-testing, yeah, absolutely. So what are some contemporary challenges some 2SLGBTQIA plus people might experience? I can put some up too if you're shy. Years-long wait lists. Thank you, Mackenzie. Yes, discrimination, access to affirming care, backlash from people who fear change, medical abuse, absolutely, refusal to treat. Yeah, those are all great examples. On the access side of things, I've put up a few important ones. So just homo and transphobia from providers, inaccurate hetero and cis-normative health systems, discrimination in gendered spaces, absolutely, fear of getting treatment, unwelcoming spaces, places, and services, fear of poor treatment, fear of being outed, fear of being misgendered, dead named, disrespected. And then, of course, all those systemic and economic barriers that Gabor Mate was talking about. So long wait lists because there's very few providers, cost of medicines. And Brianna mentioned the fertility expenses that are unequally funded for queer couples. Absolutely. And the cost of administrative changes, like changing your ID, changing your, all of those identity markers that are legally required to access healthcare to align with your preferred, with your gender and your identity. On the treatment side of things, we also see diagnostic overshadowing. I had my own personal experience where a provider assumed that I was HIV positive based on my gender and sexuality. So not seeing the person, just seeing their gender or sexuality is the issue. I've also heard many accounts of transgender people being inappropriately examined in emergency rooms and things. Of course, there's a lack of knowledge from providers, unconscious and conscious biases, homo and transphobia, being misgendered, dead named, and disrespected, blatant discrimination, long wait times for care, and the availability of medicines, and so many more. So we know that 2SLGBTQIA people, while many are receiving gender affirming and appropriate care, we know that these barriers continue to affect our community in many different ways, especially if you're racialized of an older age. Also, if you're of a younger age, there's so many intersecting things that impact on the way that queer people can access care. Yeah, and also not being reflected in research. Absolutely. When we look at those systemic problems, there's so little research that's been done that was done by and with queer people. So often it's like from that cisgender heteronormative lens that the research is even being completed, that we're erased from the medical literature. Absolutely, Ace, ableism is a big factor as well. I remember being at a conference and talking about, someone had presented research on the mental health of young people. But in their exclusion criteria for their study, they had excluded 2SLGBTQIA people. And I said to them, so the title of your study should be the mental health of cisgender heterosexual youth, because you've excluded a big population from your study. But because cis heteronormativity and heteronormativity are the default, they didn't feel that they needed to be specific in their description of their research, even though it clearly erased the experiences of queer and trans folks. Yeah, Patsy, in the epidemiology realm, definitely a lot of binary thinking. We use different regression models that simplify everything down to binaries. Absolutely. Now I want to talk a little bit about resistance and reclamation. Throughout history, including here in Alberta, Indigenous people and queer activists have resisted the medicalization and criminalization of our bodies and our existence. And I've got some dates here for some queer spaces. In 1971, the Gay Alliance Towards Equality, or GATE, was formed in Edmonton. Oops. And in 1987, GLCCE was formed, which evolved from GATE, and that all led to 2004 with the Pride Center being opened here. And then in 2015, we saw some strong advocacy for the Alberta government to demand that schools respond to gay-straight alliances. However, by 2016, only about a little over half of schools had complied with this. In terms of queer actions, we saw the first Pride Parade or Pride event being held in Edmonton at Camp Harris in 1980. The Pride Weekend came a couple years later. In 1983, the first Gay Pride Week was organized. In 84, the gala celebrations, which some people might remember, were launched. We saw our first officially proclaimed Pride March in 1991. And in 1992, the first official Pride Parade in Edmonton. And throughout history, these spaces and events have faced incredible pressure, both politically from different groups to not exist, but through community action have been able to proceed. Yeah, absolutely, Ace. It continues on, sorry. In 2019, Edmonton Two-Spirit Society secured its first location to provide services for 2S and Indigenous queer folks. And in 2022, Pride Corner was proclaimed on White Avenue and 104th Street in Edmonton, which was a response to religious hate on that corner. Of course, in 1993, that's when Two-Spirit was first described to identify gender and sexuality at an international Two-Spirit gathering in Winnipeg. In 2001, the Two-Spirit Working Group was formed. In 2002, Alberta hosted the first international Two-Spirit Peoples Gathering at the Nakota Lodge in Morley. 2003, Pride Week was proclaimed in Edmonton after Mayor Bill Smith refused for many years, and there was a human rights complaint, so he finally proclaimed it in 2003. By 2015, we started to see Pride crosswalks popping up, and 2SYEG was formed from that Aboriginal Two-Spirit Working Group. And in 2018, Edmonton Two-Spirit Society was incorporated as a nonprofit. So thinking through addressing healthcare gaps, how do we provide inclusive 2SLGBTQIA plus education in schools of health science? And this is an ongoing bit of work that I think all of our educational institutions in Alberta are engaged in. But of course, there's a lot to be done. Currently, I think gender and sexual health courses in medical school are offered as electives for medical students. They're not part of the core curriculum, at least not at University of Alberta. And there's work being done in nursing and across the health sciences to develop appropriate and non-harmful material in the curriculum. Of course, we also need education and training for our existing healthcare providers who graduated over the years and may have been influenced by the previous work that I described. So bringing them up to speed with current science and also bringing them up to realize how bias and discrimination can have a negative impact on health. We want to, of course, create safe and inclusive spaces in healthcare and health systems. And now I look for rainbows, triangles, other symbols of queer safety when I'm accessing care. And if I don't see them, I'll ask, is this a safe space for gender and sexually diverse people? And sometimes starting that conversation is enough to get some work done. I asked at a family practice, a medical family practice once, and they, of course, were and wanted to be a safe space. And so they had asked for resources to help educate all the staff on how to make it a safer space. So there is opportunity, I think, and people are eager for it. There's just not enough resources to go around at the moment. Of course, training providers in gender affirming care and increasing that capacity in the system. And then, of course, increasing those system solutions, like how do our health records and administrative processes accurately reflect the needs of our communities? Things like funding for gender-affirming care, funding for fertility treatment, those types of things that many cisgender and heterosexual people take for granted. Are there any other ideas? Same in social work? Yeah, it's an option. I see some questions about increasing funding or reinstating funding for medical gender-affirming care. Fitness accessibility, absolutely. So we know that many public spaces can be dangerous for queer and trans folks, and this, how do we incorporate that social responsibility to create safe spaces into our public spaces? Absolutely. Working through cultural humility with newcomers, absolutely. There's a lot of work to be done. So what can we do? I've got a few everyday actions here. One of the things, and I didn't do it at the beginning of mine. Wow, I usually do it when I meet clients, but I guess maybe because I couldn't see anybody, I didn't do it. But normalize sharing your pronouns. This very simple act can create safety for a gender diverse person to share theirs or start a conversation about their care needs. I often wear pins as well on my lanyards that state my pronouns. My pronouns are he and they. And often that's enough to sort of create a safer space for someone to share their pronouns and or start a conversation about their gender affirming needs. Of course, we want to provide or take training that ensures you and your team are up to date on inclusive care. I encourage people to watch queer and trans movies, films, TV, art, YouTube channels, social media. The more you know and the more you're able to humanize and relate to queer and trans people, the better able to care for them we will all be. And then, of course, once you know your team is up to speed, putting up signage or advertising safety and inclusion for your service. What you don't want to do is rush to stick a sticker on your door saying that it's a safe place if you do have staff members or colleagues who are potentially harmful. Because if I do a lot of referrals to healthcare services. So if I hear that somewhere is a safe place, I'm more likely to refer people there. And if I hear that they're not, word gets around quickly in community where safety is possible. And then, of course, I encourage everyone to do the work. Get involved and get to know to us queer and trans people. Hire us, pay us. Support queer and trans charities and organizations, go to Pride events, talk to your friends and family about queer issues. We know that these, the media is constantly full of talk about this, especially in our neighbors to the south, where we have legislators, actively trying to prevent drag queens from performing, children from reading books about queer people. There's much work to be done, I think, to start opening up dialogue and creating safer places for everyone. And I put on there, go to events and activities both during and after Pride, because I think, we've seen the corporate pink washing of Pride Month now, where everything's got a rainbow on it in Pride Month, and then everybody rushes to take down their support for the rest of the year. So I think the goal is to be as inclusive and affirming all year round as possible. I've included here a few local resources, and these links would be active if you get a copy of the slides. But we've got the Center for Sexual and Gender Diversity at MacEwan University, the Pride Center of Edmonton listed there, Edmonton Two-Spirit Society, the Firefly Institute at the U of A, the Rainbow Clinic at MacEwan University Health Center, the Wellness Center, and of course, all of the resources that are provided through Alberta Health Services, although we do know that there's a huge wait for most of those. Well, thank you all for coming. I really appreciate having this opportunity to share with you and to learn with you too. I learned a lot as well. The chat was full of brilliant stories and information. So thank you all.